Good morning, everyone. I think I'll step down. I feel much comfortable. So my name is Fady Gerges. So this is the final round. We'll just go very briefly through the strain because we have to move very fast to the stations where we get the hands-on training. So we'll get to understand the strain imaging. Why is it important? So to start with, it was invented because we need to get more meticulous estimation of the ejection fraction. For many patients who have HFpEF, amyloidosis, HOCM, subclinical dysfunction after cancer chemotherapy, we cannot get really a precise ejection fraction. So simply the ejection fraction is a small calculation, a stroke volume divided by the end-diastolic volume in percent. So it's a very easy equation. The thing that we have a lot of ways to get the ejection fraction, or multiple methods or parameters. We have the symptom method or the biplane method. We have the M mode. We have the 2D, which is very accurate as well. Even the 3D method. And it's very much comparable with the ejection fraction through the MRI. Recently, there's a lot of studies about this. So, for example, this is a biplane method. You can see that we do some endocardial lineation of the endocardium, and then we can get estimation of the two-chamber diameter in both systole and diastole, for 2 chambers and 4 chambers. So the end diastolic volume, good idea. Sorry. So the end diastolic volume and systolic volume are calculated basically through the machine. It's a very simple math. And then it can go like that. 2 chamber, both systole and diastole, and 4 chambers, same thing. You get the diameter, disc heights for both, and then the imaging will be calculated, acquisited by the machine, and you get the values. The M mode, this is the oldest one after the 2D method. Sometimes in normal patients, it's quite accurate, but in abnormal patients, it's a little bit challenging. Like patients, for example, who had HOCM, amyloidosis, HFpEF, then we have to go for other parameters for sure. So, for example, this patient, you can see here that this is almost a normal echo for a normal patient. The LV, the RV, contractility, ejection fraction, thickening of the myocardium, everything looks perfectly fine, right? However, for this patient, if you take a look by just the eyeball, you can see there's something wrong. The apex is completely dyskinetic in all the views, 2 chamber, 4 chamber, 3 chamber. So probably this patient had cardiomyopathy. So how to get an estimation, a good meticulous one for the ejection fraction? So the thing that with these kind of patients, there's a lot of limitations if you go for the biplane method or the M mode, specifically the M mode, to be honest. It's not accurate. If you have arrhythmia, if you have severe mitral regurg, patient had the frequent PVCs or atrial fibrillation, even if you don't have a good view, like a poor endocardial delineation, a lot of trapeculations, for example, patients who have LV non-compaction or severe dilated cardiomyopathy, then you will get very much difficulties in getting a good delineation for the endocardium. Even apex foreshortening, it's very common. We'll go to the hand stations after that. I'll show how to avoid the apical foreshortening. So this is the reason why strain was there, because EF is basically load dependent. So it relies on the end diastolic volume. We're talking about the preload and the afterload. It's all physiological. Any of the previous diseases or pathology the patient have will affect the ejection fraction because it's load dependent. So look at here, this is very important, the orientation of the myocardial fibers. So we have 3 different orientations. One through the endocardial, like the one we will discuss today, the global longitudinal strain or shortening. You can see the direction of the contractility and the strain of the spicules. Mid-wall, which is a radial shortening, and the circumferential shortening with the epicardia. They will not be the scope of our workshop today. But you can see the heart is not moving as you can imagine, just a plain contractility. It's a twist and torsion. So you have the base, you have the apex, they're moving in different directions like that. So clockwise and anti-clockwise. So this is basically the contractility of the LV. It's not just mere contractility, it's a torsion and LV twist as well. So, like I said, we have a lot of applications for this concept of deformation or strain, assessment of the subclinical systolic dysfunction. Like the patient who are, for example, taking anthracyclines. You have a reduction in the EF, but you cannot tell it when you do M mode or biplane. You have to use strain imaging. So after 3 months of starting anthracyclines for specific patients on cancer chemotherapy, it's very challenging to get proper ejection fraction just by the plain methods we have. So look at this. This is the strain basically. It's a very easy illustration. So this is a myocardial fiber. So this is during contraction. This is during baseline or diastole or relaxation. So we're talking here about both the radial and longitudinal strain. It's briefly a change in the length of the myocardial segment in relative to its initial length before contractility. So look at this. It can be shortening because this is the baseline, and on contractility or systole, this is the shortening and the thickening. On the other way around, if diastole is occurring, the opposite occurs. There will be lengthening and thinning of the myocardial segment. And this is actually the basic concept of the deformation. So we have the strain rate and the strain deformation itself. We'll talk about this also during the stations. So basically in echo, it uses for myocardial muscle change throughout the cardiac cycle, frame by frame, how the deformation occurs. Why it is important, we've spoken about the subclinical systolic dysfunction. There's a lot of many other applications. We'll see it as well in the hands-on training. So why we call it also the spicle tracking imaging? Because you can see here that there's very small spicules inside the myocardium. This is real, and they are very small, and they're looking like grain-like pattern. So the software of the machine of the echo, they track these small spicules, like the grain pattern, and they can, after that, do the pattern of the strain. So that's why it's called deformation. So they track the spicules along the endocardial borders in all the views, 2-chamber, 4-chamber, and 3-chamber. At the end, they constitute a whole image about the values, which we will say later what are the normal values of the strain. So, for example, this is a normal strain. We call this a bull's eye. Just imagine you're doing an echo and you're having a short axis, parasternal short axis for the patient. So you can see this is the anterior septum segment, this is the anterior, lateral, posterior, inferior, and anteroseptal. So the middle one is the apex, and then you go to the mid wall, and then you go to the base. So this is the same segmental wall motion of patients who have, like, for example, hypokinesia or dyskinesia and the echo on the short axis. So you'll not be confused. This is the same for the bull's eye. This is a normal patient. Look at the tracking. We track the whole endocardium from the inside through the 4-chamber, 2-chamber, and 3-chamber. And then you get the strain rate and the peak rate as well. So why it's with negative, not with positive? Because there is shortening of the myocardial fiber. So there is shortening, that means the values goes to negative. And when it's more negative, that means the patient is doing better. So the ejection fraction will be higher. So the normal is -20 plus or -2. And in some literature also they say that starting from -16 as a value for global longitudinal strain, this is normal. So this is another patient that doesn't look normal. So look first at the color. We have seen here that usually the red color is the good one. You get more negative values, which is a good strain. So whenever you go more pinkish or light pink or blue, that means there's problem with these segments according to the resting wall motion and according to the views. Like, let's see this blue area, for example, the lateral basal part, it is completely hypokinetic and it could be akinetic. That's why, according to the legend of the colors, the GLS is -8 and then -6. And sorry, this is 8 and this is -6. 8 is worst even, that's why it's going to blue. So you can see the same segment over here in the lateral basal wall. So it's 8. So it exceeded even the negative value. That means this segment is quite depressed. Okay, it could be akinetic or maybe a post-MI patient. This is again a normal patient. Look at the bull's eye. It's completely red. All the values are with negative and mostly are above -18, -19, -20. And look at the endocardial quotient, how we track it here. They are different softwares. These are Philips, GE. Today we're going to train on the Philips, so there's not much difference. It's all about softwares. And this is a live patient. This is my patient, actually, from last year. I just had to put it here, the 3 views, and then the whole strain, so I can show how we can track it. So look at this. You start at the hinge point of the both mitral valves, and then you go and you do the delineation from the inside, and you still can see the contractility of the muscles here in the endocardium, but you cannot cover more than that. So if you just go beyond this line to the mid-septum, for example, of the mid-wall, that will not be accurate. So you have to be at this level exactly. Look at the values. It's all by negative, and it's mostly above -17. This is a 4-chamfer. Then we took another view, 2-chamfer. Same, hinge points, we start at then, and then we do the endocardial delineation, and you can see the values are all almost normal. This is the last view, 3-chamfer. Like we said, we have to get proper 3 views so we can get a good strain. All the values looks really good. So this is the end. You can see here that the average global longitudinal strain for the endocardium is -21, which is normal, right? So you can see here from that the bull's eye, it all came with negative values, and it's all deep red. That means the patient is having a completely normal ejection fraction. So, well, this is the same. So the cases for demonstrations will finalize by this. We'll have a couple of cases, so you'll get the hands of it. This is a 64-year-old patient, previously healthy, admitted after midnight with acute chest pain, suspected of acute coronary syndrome. So his ECG was non-conclusive, but his troponin came high. Look at this 2-chamfer view, and look at that yellow curve, which at the aortic valve closure, it turns to -10. -10 is low, and this is correlates exactly with the basal infraseptal wall, which is basically correlate with the right coronary artery, right? This is the same territory. So we did angio after the troponin came high, and we found that he had severe, almost 90% stenosis of the proximal RCA. See how much the strain correlates really well with the culprit lesion, even before we do coronary angiogram. This is another patient as well. You can see that this patient is not normal. The average peak GLS is -13. And you can tell from the bull's eye the areas which are affected that goes really lower than the -16, and it's more lightish pink, more than the good areas which are red. And then you can go by the territories. So you can tell from here that the apex is involved, right? -5 and -3, this is the apex. It doesn't look good. So this patient had an LAD infarct. Another patient who had an LAD infarct, you can see from the bull's eye that the areas which are being affected by the culprit LAD are also affected. See the lateral wall, the anterior wall, and the anteroseptal, starting from the apex to the mid wall to the base. They are all involved. Here, the numbers are was positive, and this is something bad. We said that more negative is more good, right? How do we use it in the clinical practice? Let's see that this patient we're just talking about, that he had chemotherapy, and he was on anthracyclines. We know that the anthracycline is one of the main agents that can cause cancer-induced cardiomyopathy or LV dysfunction. So this is 1 month, and this is 3 months after initiation of the medicine. The ejection fraction is completely the same, 50%. However, look at the bull's eye here, it's completely normal. It's all red, deep red. However, here, the posterior wall is involved, and the GLS became depressed, -13. It's not -18 as here. So the GLS decreased from almost like 27% difference if we compared. And this is only 3 months after starting anthracyclines. So do not rely on the basic ejection fraction by M-mode or the 2D or the symptom when you assess these patients who are on cancer chemotherapy. Another patient, this is a very famous pattern for cardiac amyloidosis. We call it the cherry on top. Look at the cherry here, this is the same. So basically, we know the pattern of the apical sparing of the patient. The apex is completely normal. However, the mid wall and the base are involved. And you can see that there is, on the other hand, the ejection fraction is perfectly normal in this patient. GLS is quite depressed, right? -11. It's due to these areas which have reduced contractility. But you cannot see that on the eyeball as well, which is tricky. That's why you have to use the GLS. That's why they use the GLS in the assessment and the stratification of patients with HFpEF. It is in the criteria. If the GLS is less than 16%, this is one of the minor criteria to diagnose HFpEF. Even if you correlate those patients with the CMR or the cardiac MRI, look at this patient. The all segments are completely fine. However, the posterior wall, especially the basal segment, is reduced here. The values are almost -3, which is quite depressed. And this is the CMR of the patient. You can see that the mid wall of the posterior basal segment in the basal segment of the short axis, when you do the MRI, it's also involved. There is late gadolinium enhancement. Look at here and there. So it correlates well with the CMR as well. So patients who had coronary heart disease as well, this patient had significant stenosis in both the LCX and the RCA, and there is post-systolic shortening. The GLS is depressed in the same culprit area of the LCX and the RCA. Athletic heart, this is very common, and we see that patients who are athletes, sometimes they had LVH. We don't know if this is a pathological or a normal one. Sometimes they have a dilated LV or even dilated LA. The volumes are a little bit high, so the ejection fraction can really come even by the biplane method depressed, like 46%. This is by symptom. However, when you do strain, it's wonderful. Perfectly clear, right? It's completely normal. LV hypertrophy. Patient who have end-stage renal disease with LVH, HOCM, you can see ejection fraction is perfectly normal, 65, 73. GLS is depressed. So do not rely in these patients on only the ejection fraction by aim mode and symptom or even by your eyeball. At the end, I think the only limitation for the GLS is basically the technical issues. So if you get a good view and the patient has a very good echo window, then you will master the views and you will get a very good outcome. But the thing that, what I'm saying that, let's say patient morbidly obese or patient like slim or very thin, they might have a poor view. 4-chamber, 2-chamber, or 3-chamber. You will not be able to get a good GLS, and do not rely on GLS in these patients because it will not be accurate. Thank you very much. Thank you.